Okay. I would like to thank the Voice Foundation for making this virtual symposium possible. So I will be presenting some of my doctoral work that I conducted at the Medical University of South Carolina under the mentorship of Dr. Heather Bonilha. And this is part one of two presentations on respiratory function in patients with Presbyphonia. This part is a cross-sectional mechanistic study, and the other video I'm presenting is an intervention study. This research was funded in part by a grant from the Center on Aging of the Medical University of South Carolina. So Presbyphonia, as we know, this is a voice disorder that is mainly caused by age-related changes in the laryngeal system, resulting, among other things, in vocal fold atrophy and bowing, in the glottal gap during phonation, and in a decreased ability of the vocal folds to provide resistance to airflow. And because of these changes, air escapes more quickly during phonation, so speakers tend to make shorter sentences. It's also harder for them to build up subglottal pressure below the vocal folds because of the glottal gap and because of the decreased laryngeal resistance. Their vocal fold quality is often breathy and soft, and they have trouble being heard and understood. And in addition to changes in the larynx, there are also age-related changes that occur in the respiratory system, which are likely to further affect phonation. What happens with aging is that the lungs lose some of their elastic recoil, so they are more compliant, and the rib cage becomes stiffer and less compliant, so less natural expiratory pressures are available for phonation. And on top of that, there are changes in the shape of the thorax that affect the mechanics of breathing, and there's also a decrease in respiratory muscle strength. So although the total lung capacity usually remains the same, there is less air and pressure available for phonation. So we wanted to explore the relationship between respiratory function and voice in these patients. In other words, do patients with a lower respiratory function present with poorer voice outcomes than those with a higher respiratory function? And therefore, is it relevant to tackle the respiratory system as a therapy target along with voice exercises? The study was conducted at the Medical University of South Carolina, where we recruited treatment-seeking patients who were diagnosed with Presbyphonia by the laryngologist on the team, Dr. Lucinda Halstead. And we conducted different voice and respiratory assessments on the participants, and then we used a combination of analyses to uncover the relationships. Because we had many measures, we started by conducting a factor analysis to extract the main respiratory and voice constructs. And then we did a cluster analysis to identify groups of participants with similar profiles. And to further understand what came out of the cluster analysis, we ran correlations between all the respiratory and voice factors. And lastly, we used linear regression to identify specific respiratory predictors. So I will briefly go over the results. We had 21 participants, 11 were males, 10 were females. They had a mean age of 72 years old. They all had voice characteristics consistent with Presbyphonia and reported voice-related handicap. And the cluster analysis created 3 groups with distinct characteristics based on the respiratory and voice factors identified by the factor analysis. And the clusters were shaped partly by age. Cluster 1 had a mean age of almost 80 years old. Cluster 3 had a mean age of 60 years old. And cluster 2 was in between. And what we see on the slide are the results for 2 respiratory predictors: forced vital capacity, FVC, and forced expiratory volume in 1 second, FEV1. And they are expressed in percent predicted values, which take into account age, sex, and height. Now, while cluster 1 and cluster 3 had a good respiratory health, cluster 2 had a significantly decreased pulmonary function, with percent predicted values way below 80% of what would be expected for their age, sex, and height. So these participants really differed in terms of respiratory function, and we wanted to know, do they also differ in terms of voice? And when looking at the means for the voice factors, we found that they did. So these are standardized mean, and I won't go into the details of each factor, but in summary, cluster 2, which had a lower respiratory function, also had a higher aerodynamic resistance, a higher hyperfunction, so more supraglottic activity. They had a lower pliability of the vocal fold, which was a factor comprising vibration amplitude and amplitude of the mucosal wave, and they had higher reported handicap. So this was suggesting a relationship between a poor respiratory function and voice physiology, which could not be explained by chronological age, but also could not be explained by physiological aging, such as a more advanced disease process in the body, because these patients did not have a more severe atrophy. So it really seemed to be a biomechanical relationship. And here we see how a lower respiratory function was associated with a greater aerodynamic resistance. And hyperfunction, which was also elevated in cluster 2, was correlated with resistance. In other words, participants with a very high laryngeal resistance necessarily had significant hyperfunction. And this makes sense because, as I mentioned before, patients with presbyphonia have difficulty increasing resistance with their true vocal folds because of the atrophy. So they tend to involve the supraglottic structures, as we see here on pictures from our participants. And by doing that, they can control the airflow and not run out of air so quickly. And they can build up subglottal pressure more easily, which is even more necessary if they have an impaired respiratory function. And this increased hyperfunction could partly explain the inverse relationship that was found between pulmonary function and self-reported handicap. And this was a pretty strong relationship, explaining approximately 35% of the variance. And we built this model to summarize all these relationships, and the size of the arrows is proportional to the correlation coefficient. So we see this physiological pathway through which respiratory function can impact handicap, involving decreased pliability of the vocal folds, increased laryngeal resistance with hyperfunction. And then there's also this general impairment pathway in which an impaired pulmonary function may directly affect reported handicap. And that is because individuals with poor respiratory health may already experience impairment from shortness of breath, for example. And this discomfort is likely to be aggravated by speaking, especially considering the loss of air through a glottal gap. And this could make the individuals less functional in that they are less inclined to participate in any communication activity. Interestingly, the severity of the atrophy and the voice quality were associated, but neither of these components played a determinant role in the handicap model. However, this was a pilot study, and the influence of atrophy and voice quality may become significant in a study with a larger sample size. So, in conclusion, poor respiratory health exacerbates the burden of vocal fold atrophy, and therefore implementation of respiratory screening prior to starting voice therapy may affect the outcomes of treatment in this specific population. There might also be relevance for a respiratory intervention, considering the age-related changes occurring in the respiratory system. So I thank you for listening, and I hope you have a great online symposium.